Hello, everyone, and welcome to the second activity of our special series, Through the Looking Glass, Seeing a Better Future in Crohn's Disease. I'm Dr. Aline Charabaty, Associate Professor of Medicine at Johns Hopkins School of Medicine and Medical Director of the Division of Gastroenterology and Hepatology and Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital. I'm joined today by my good friend and colleague, Dr. Michael Dolinger. He's Assistant Professor of Pediatric Gastroenterology and Associate Program Director of the PEDS GI Fellowship Program at the Icahn School of Medicine and the Mount Sinai Kravis Children's Hospital in New York City, New York. Mike, welcome, and thank you for being here.
Hi, Aline. Thank you so much for having me. Very excited.
Over the next few weeks, we will have different activities such as short webinars, tutorials, clinical vignette discussions, all focused around treatment targets and monitoring of Crohn's disease. All these activities are CME certified and jointly provided by PACE and Bonum CE and made possible with the support of an educational grant from Lilly. Our disclosures are shown on the screen. And if you haven't already completed our pre-activity survey, please do so by clicking the link below this video or by scanning the QR code shown here. Let us know who you are, and don't forget to complete your evaluation at the end of the session and claim your free CME credits. And of course, follow Monday Night IBD and Bonum CE and set your alert notification for more CME certified programs. So 2 weeks ago, we had a discussion with Dr. Kinuken about the role of endoscopy to objectively assess disease activity and monitor treatment response in Crohn's disease. Today, with Dr. Dolinger, we're going to review the non-invasive imaging techniques and their role in diagnosing and monitoring treatment response in patients with Crohn's disease. So, we have different non-invasive tools to assess Crohn's disease activity and treatment response: CT enterography, MR enterography, and now intestinal ultrasound. So can you start us off by discussing the different type of imaging, how good they are at assessing mucosal and transmural involvement with Crohn's disease, and what are their pros and cons?
Yes, absolutely. And this is one of the biggest questions we get asked is, what is the role and where does intestinal ultrasound fit into the monitoring of inflammatory bowel disease? Ileal colonoscopy is needed for diagnosis. It's really the only way to get a piece of tissue and assess the mucosal lining. It doesn't see the proximal small intestine, and especially in children, which I practice, it may be very difficult, especially with difficult to do preparation, and you need anesthesia and sedation. But then you say, okay, we've done a colonoscopy for diagnosis. What are we going to do to assess the proximal small bowel? What are we going to do to assess repeatedly over time? So this is where we use intestinal ultrasound. We use intestinal ultrasound as a non-invasive tool without preparation, without the need for anesthesia and sedation, to assess both the colon and the small intestine. It's a regular abdominal ultrasound, and really it's done in 5 to 10 minutes. And what we're able to do is we're able to see transmural inflammation. What you just pointed out, we don't see the inner lining. We see the outside wall in. But all inflammation and inflammatory bowel disease actually has transmural findings, which we're able to detect by seeing the individual layers on ultrasound. This translates and correlates with mucosal inflammation that we see on colonoscopy. When we're looking at the small bowel, if we want a non-invasive option to assess the mucosal inner lining without getting tissue, this is where there really is a benefit to using wireless video capsule endoscopy. And we don't need so much bowel prep, especially in children who can swallow pills. And adults, this is a really great way to assess the mucosal inner lining that matches with intestinal ultrasound. Now, where does intestinal ultrasound fit in with our traditional cross-sectional imaging techniques? There is still a lot of value to MRI and CT. MRI is better than intestinal ultrasound to assess proximal small bowel disease beyond the terminal ileum, and it's better to assess the extent of inflammation. However, you need oral contrast, you need IV contrast in our younger children. It's really not feasible because you still need sedation. You often need fasting, time off of work, and it's not a repeatable, cost-effective modality. So what we do is we say MRI is great at baseline to match with that diagnostic colonoscopy. When you're going to have intestinal ultrasound, you benchmark it at baseline with those findings. And then you use intestinal ultrasound repeatedly over time, knowing how accurate it is to that patient's disease specifically for them. And CT also still has value, especially in the emergent situation when you need a fast assessment and the assessment of complications. And we're going to talk more about the accuracy of all these modalities and complications. CT still has significant value. So I think overall, there's value in each of these modalities in understanding mucosal and transmural inflammation, especially at diagnosis or restaging, and then how you use them repeatedly over time to monitor disease in a tight control monitoring algorithm and a treat to target approach. This is where the real value of intestinal ultrasound comes in as this repeatable, non-invasive, easy modality that's accurate to the other modalities.
So, Michael, you bring up a good point, about accuracy. So we're all very familiar with ordering CT or MR enterography. How good is IUS at assessing disease activity and Crohn's complication compared to those traditional imaging modalities?
Intestinal ultrasound is excellent in accuracy to those modalities. So when we think about first intestinal ultrasound's accuracy to colonoscopy, it's very accurate. Ultrasound has a sensitivity and specificity above 90%. It's as accurate as any modality to detect inflammation. When we think about accuracy to other modalities like MRI and CT to detect complications, this is where intestinal ultrasound has very similar accuracy. And we're going to use it as a first-line screening tool for these patients. And when you're thinking about complications, this is where it actually matters who the operator is and what your experience is. If you've just learned intestinal ultrasound, it may not be the most accurate. You may not be the most comfortable assessing for strictures, assessing for fistula, assessing for abscesses or inflammatory masses. Over time, just like any procedural skill, you'll become more comfortable. But still, you're going to want to validate that with cross-sectional imaging like CT or MR, knowing that they are as accurate. But what the advantage of intestinal ultrasound provides is when a patient has symptoms, when a patient's concerned that they may be having fever, pain, new onset bloating, distension, nausea, vomiting, you bring them into the clinic rather than the ER. You perform intestinal ultrasound, which has very similar accuracy for all of these complications, and you use it to talk through the patient. Okay, actually, we're going to send you to the ER. We're going to get a CT because we're concerned you have a new abscess and we need to treat that immediately. Actually, we're very confident you don't have an abscess. We think you have an infection. We see this on an intestinal ultrasound, you've caught a bacteria. The value is not just in the numbers of how accurate it is, it's how you can use this as a real-time tool to explain this to patients about what's going on. And then you understand how you can triage decision-making so much faster using intestinal ultrasound as the primary screening modality for complications.
I love this. I mean, I can only imagine how rewarding this is and how reassuring it is for a patient and for us as clinicians to really be aware to triage which patient need further testing, ER, or reassurance, and different kind of evaluation. And this is something I haven't thought about, so I'm glad you bring it up. So you mentioned how you often combine both tests, especially when you're suspecting maybe a complication or early when you're not very when you're just starting to do IUS, maybe complementing it with more traditional imaging can help you identify complication. So tell me, what do you do in your practice in terms of using the IUS? Do you use it as a standalone test? When do you combine it with other tests? And how do you use it through the patient journey from diagnosis to monitoring to assessing for complication like you just described?
You really want to be sure you're making the right decision for every patient you're doing with the best knowledge you can. And it's your own confidence in what you're seeing for that patient that you then need to translate into what to do. And over time, you will become more confident and more confident in what you're seeing. So what we do in our practice currently is different than what we did a year ago, 2 years ago, and 3 years ago. Now, here, we take anybody who has a known complication. Say you have a stricture and you have small bowel stricturing disease that we've seen on MR or CT. We benchmark that with intestinal ultrasound, and then we use intestinal ultrasound to follow them serially. And we're going to monitor that stricture more often when you're feeling well. We're going to see that over time, every 3 to 6 months. We're going to repeat intestinal ultrasound imaging. Again, no contrast, no fasting, no prep. These patients often, especially if they're elderly, have multiple comorbidities. They may be not on therapy. They may have had multiple surgeries 20 years ago. They're 75. You don't want to put them through another surgery. We're going to monitor your stricture with ultrasound and make sure we're catching it before it progresses to an obstruction if we can. And we're intervening only when we have to, and we're kind of guiding you with this tight control monitoring approach that's a little bit different. That's one of the main ways we follow strictures. We catch fistula and sinus tracts and severe inflammation in the terminal ileum that MRI may miss. The way I explain for fistula is that MRI, the assessment, is like you are in a plane flying over a city and you're assessing fistula, which are on the ground. You may see these tiny little cars, but you may miss the little tracks. Ultrasound is like a magnifying glass on the ground when you're standing there. You're going to catch all the little subtle sinus tracts and maybe a small anterior fistula that you may miss on MRI. You're not going to get that totality of the proximal assessment, but you're going to catch, especially in the distal ileum, these subtle findings, breaks in the layers that you really see as actual complications in the beginning or healing of fistula tracts. And then in abscesses or inflammatory masses, ultrasound is really, I think, the best modality to assess this. You may get, if there's stricture and bowel dilation complicating it, it may be difficult for ultrasound with obstructive bowel gas to see. But for most cases, ultrasound is really an excellent tool to see that you have a mass, you have a complication, you have a stellate fistula and a kind of a conglomeration of bowel loops. And we can use that as a screening tool. There, we're going to send you for more acute management. We're not going to follow you repeatedly over time, most likely. But if we send you for drainage, and then we see in the clinic that that drainage is resolved, okay, we're not going to send you to surgery. We're going to start an anti-inflammatory therapy. Then you may have surgery later. This is kind of the nuanced approach for each different complication and how we're going to use ultrasound in practice. It's very different in each complication that we're following.
This is phenomenal. So, I mean, what I gather from you is that IUS has comparable sensitivity and specificity to MRI and CT in assessing disease activity and extent and complications, but it also has the advantage to be done on site at the time of visit. So the diagnosis is not delayed, and you can, like you described, triage patients and the how acute and how what kind of level of care they need. It has a lower cost, a low patient time commitment compared to other tests. There's no need for patient prep, which is amazing in itself, but also it allows you, like you're describing, closer monitoring. We cannot order CT and MR every few weeks to see how the patient is progressing, if the stricture is getting worse, or if the fistula is developing into more complication. But with the IUS, this is a tool that you can use more frequently and monitor closely patient and adjust, I presume, also treatment according to what you find. And I think that's probably is going to lead to better patient outcome with that close monitoring and adjustment of treatment, etc. So can you walk us through specific cases in your practice where you used IUS and how it impacted your management and the care of patients?
The case I'm going to talk to you about today is a case of ileal Crohn's disease and really highlights how we use intestinal ultrasound as a monitoring tool in all stages of ileal Crohn's disease. So it's a 21-year-old male who comes to the clinic feeling pretty well. He has occasional abdominal pain, maybe once or twice a week. He has maybe intermittent diarrhea a couple times a month, but for the most part, he has foreign bowel movements. He feels good. He's living his life. He's working as a fast food worker, and he doesn't really think about his Crohn's disease. He's switching therapies. He just moved to New York City, and we're going to do an initial assessment. He's been treated with adalimumab for the past 3 years on 40 milligrams every other week. He's had levels that have been therapeutic. And overall, you get the assessment that he's in clinical remission and he's feeling well. What I want to highlight is he's never had ultrasound-driven care. So the first thing we do after meeting him, hearing his story, is we put the probe on the patient. And this is what you're going to see. You may have never seen ultrasound, and I'm going to play this video back and forth for you over here. So you see the terminal ileum over the iliac vessels, those round circles, and over the psoas muscle, and coming back here, the thickened terminal ileum into the cecum to the ileocecal valve. I'm going to play that again. Terminal ileum that's thickened, it's inflamed for a short segment, about 8 centimeters over the iliac vessels. You can see that across your screen. The white, black, white, black, white layers of the bowel wall going into the cecum. We have a thickened terminal ileum. So even though he's in clinical remission and he feels well, he never had a treat to target colonoscopy. He's been on adalimumab for 3 years. We say to him, I know you don't undergo a colonoscopy, but guess what? You have inflammation on ultrasound, and we want to make sure this doesn't progress. that you don't require surgery in your future. And if you do, we want to do surgery when you don't have complications, when you don't have penetrating disease. We want to see what's going on. We want to see if we need to switch therapies to actually get healing, even though you feel well. So we do a colonoscopy, and this is what you see. You see inflammation, ulcers, edema, erythema, and you actually see an inflammatory narrowing. And we see that on ultrasound. You see that he had thickness, and that correlates endoscopically with ulceration, edema, and swelling, and it matches. And so now we know, okay, even though he feels well, we need to make a change. If we stay on this therapy that he has therapeutic levels for the last 3 years, we need to switch, or else he's going to have disease progression. So what do? We say, okay, you didn't respond to anti-TNF therapy. We're going to switch class. We're going to go to ustekinumab and target IL-12/23 and switch class altogether. He's feeling well, so we don't think we need to jump to maybe a different class, maybe a small molecule. We're going to go right to an IL-23. So now we have baseline. We want to make sure at induction, after we get approval, it's a month later, at his IV dose, we bring him back. Ultrasound is the same. So you can see here a thickened terminal ileum, again, over the iliac vessels, tracking it back to the cecum. You see inflammation. He feels well, so we can't monitor his symptoms. He actually has normal labs and a normal calprotectin. So nothing is able to monitor this besides ultrasound. We bring him back. 8 weeks later, we are looking for treatment response. Treatment response is, again, not going to be his symptoms. He has none. It's not going to be his CRP. It's not going to be his albumin. It's not going to be his hemoglobin. It's not going to be his calprotectin. We need to see change in actual inflammation, and we need to directly visualize that. We're not going to repeat an MR every 8 weeks. We're not going to repeat a scope in 8 weeks. What we're going to do is we're going to repeat an ultrasound, which we know, based on his baseline, matches his endoscopy. So you can visualize this in the clinic, exactly what's going on in the inner lining by using this non-invasive transmural assessment. So 8 weeks later, when we do his injection training, ustekinumab, we see here, guess what? He still has thickening of the terminal ileum. And we don't have a decrease in 20% of the bowel wall thickness, which is what we look for. We're looking for a 25 or 20% decrease. We see that the thickening actually is the same. It's the same segment. It hasn't progressed. But you see lymphadenopathy. He still has active inflammation. Based on this alone, we escalate his therapy. We escalate him to ustekinumab every 4 weeks. And we see, again, at week 16, now he's gotten 2 every 4 week doses. He still has increased bowel wall thickness of the terminal ileum. He still has active inflammation. And it's not just that the thickness is still increased, it's the same. That thickness is not moving. Now you have a patient who hasn't responded to anti-TNF therapy. He hasn't responded at all to escalated anti-IL-23 therapy. Do we want to give him another IL-23 therapy? Do we want to give him a small molecule? Or now we begin the conversation about, even though you feel well, should we be proactive about a surgical approach? Are we not treating active inflammation anymore? And maybe we've gotten rid of that active inflammation. And are we going to repeat a scope to see, but how much of this is fibrotic? How much of this is scar tissue also? And are we ever going to get normalization? And that narrowing that we saw on scope, is that going to progress? So we start this conversation early throughout the process and get buy-in. And the patient then understands exactly what we're trying to do. And nothing comes up out of nowhere. He can visualize that the inflammation is the same. And because he feels well, this is the only way in which we're going to monitor this. Eventually, we're going to repeat a colonoscopy. We may get an MRI, but in the interim, we're building this conversation over the course of the last 6 months. Well, he's been on adalimumab and ustekinumab, using intestinal ultrasound to drive the entire conversation. What I can highlight about intestinal ultrasound that gets lost in the data and the numbers, when you put this into reality and into practice, intestinal ultrasound becomes the captain or the quarterback of your care and your management. It is not the only way to assess inflammatory bowel disease, but it becomes the best way and the most precise way to start to triage and distribute to all the other tools that you have available to provide significantly better care for your IBD patient. It's like a quarterback throwing it out to your receiver, throwing it out to your running back. You're going to send this off to MRI. You're going to send this off to your ER. You're going to get it to your surgeon. You're going to make decisions so much faster, and you're going to provide better care for your patient. And your patient's going to understand all that so much better.
I love this comparison. I totally love it. And, whether they are football fans or not, many of colleagues are excited about making IUS available to their patients. But what I hear from most is that they are not sure how to start the process and how they can get the buy-in of their institution or practice leadership. So Mike, can you give us some guidance on how to start an IUS program and have a comprehensive football team in your IBD practice?
Yes, this is not rocket science, but it is daunting. And people find it challenging to go up against the inertia of changing practice and changing care. No matter what you're doing in whatever field, medicine or not, it's hard to change something that's established. But what I can say here is it's so impactful to both your own management and patient management that I think there's enough evidence out there that this needs to happen for IBD patients. And when you feel that something needs to happen, it takes a village and you have to engage that village and team. And so this cannot be done by one individual, no matter where you are at a private practice, at an academic center. You need support and you need to engage the entire team early. This includes your division chiefs, your business associates, your division administrators, all of the IBD physicians, not just yourself. You can't just order ultrasound for yourself and bring it into care. It needs to be incorporated into practice. And everyone needs to understand how you're going to use this. The nurses, the nurse practitioners, the medical assistants, radiology, information technology, the electronic medical record. You need a systematic approach, have meetings to engage all these people and say, we're actually going to change care in our practice for IBD patients by incorporating intestinal ultrasound. This isn't some just novel tool we're going to do in some patients. We're going to start. And we're going to have a model where we don't know. We're going to learn what our experience is, and we're going to constantly adapt. And we're going to constantly reevaluate and try and improve this. We're doing something new. We don't know the perfect way to do it, but we need to get started. And there's some basic things you need to get started. And that is, you need a machine, you need a plan, and you need a way to train, and then you need a way to practice, most importantly. When you want to actually become certified to perform intestinal ultrasound, there is actually a very straightforward process, and we make it easy to get the education and training that you need. And this is a standardized approach with the rest of the world, and it creates this standardization for IBD and allows for better care overall. The International Bowel Ultrasound Group has created a 3-module certification process. You can go to their website, and it's important to start applying for training and certification to attend the courses to begin to understand the standardized technique in order to do this. As you do that, you want to do things in parallel, starting your institutional credentialing process, making sure that you get an ultrasound machine to be able to do this in practice. When you learn this skill and you bring it back to your group, you don't want to have a 6-month delay. You want to have a machine ready to go. And it's not just getting a machine. You need to have IT make sure that you can take the images, store them in the electronic medical record, that you're able to report and create a documentation template in the chart, and that when you're ultimately ready and you feel comfortable to bill this, and you're not just practicing anymore, and your patients aren't just volunteering and you're using this to change care, you want to get this as a reimbursable and sustainable modality to monitor IBD patients. And that you need to work with your billing and administration department, because this is reimbursable and there is a CPT code for limited abdominal ultrasound that you should be using.
I love this, Mike. This was such an insightful conversation, and truly not just about the data on how accurate IUS is in diagnosing and monitoring disease, but really putting IUS in the context of patient care and almost instant care, better monitoring. And I love the fact that you're conveying the message to people starting IUS that it's okay to start small and then grow bigger, become more comfortable using it, and how you would use it in your practice. And I really love how you put in the patient perspective in here, how these conversations that goes around the IUS finding can really reassure the patient, triage the patient, and really collaborate with the patient. I really feel it's a great tool in a better patient and physician collaboration and communication, and really taking away the barriers of cost, radiology, excessive tests, waiting time, ER visit, and really kind of recentering the care around the patient and partnering with them. I did not expect that from this conversation. I thought it's going to be all data and amazing data, but I'm glad you're showing like the human side of IUS, whether from the operator, the clinician doing it, but also from the patient, and how this can really improve and elevate the care of patients with IBD. So just to review the main points we made in this conversation, intestinal ultrasound is a low-risk, low-cost option for non-invasive and objective disease assessment and treatment monitoring. It really requires little patient preparation, allows on-the-spot decision-making and discussion with the patient. IUS can be used throughout the disease course to monitor treatment response, monitor potential complication, assess for disease flares and activity. IUS is very comparable to more familiar imaging modalities such as CT, NMR, enterography, and implementing intestinal ultrasound program requires specific training and the engagement of key stakeholders in your practice or institution, but mostly it requires patience and really becoming comfortable, progressively comfortable from diagnosing IBD or Crohn's activity to diagnosing complication and monitoring treatment response. So thank you, Mike, again for all that insight, and thank you everyone for joining us. Please complete the post-activity polls in the tweets below or by using the QR code shown on the screen. And don't forget to claim your free CME. Click like and follow for more social media-based CME content from Monday Night IBD and Bonum CE. Thank you.